Thank you very much for this invitation to join you and talk about a very important topic, a topic that I've researched and also been engaged in quite a bit of clinical work. That is both direct clinical services as well as supervision. So this is a topic that is very near and dear to me. Thank you also for getting up early for this session. For me, it's Monday or Tuesday evening, and I believe it's Wednesday morning for all of you. So I do thank you again for getting up to hear this topic. What I'd like to do is talk about several topics with you related to this. And the first is to talk about the types of trauma so that we are all familiar with the types of trauma that could involve catastrophic natural disasters as well as human disasters and also critical incidents that can occur. So I'd like to talk a little bit about those and then give you a little bit of a background on disaster mental health responses for children and adolescents. So where does this work begin? When did we start thinking about how to respond to children and adolescents and how our clinical work might be different for them developmentally than it might be for adults? And then I'll move on to talk about children's responses, and I think that's probably the most interesting part of this presentation. It's what most people get excited about, and that is how can you detect? So if you're doing screenings, if you're assessing, if you're doing case conceptualization with children whom you've suspected of experiencing trauma or are currently impacted by trauma, what should you look for? And then also the idea of the effects, primary and secondary effects of trauma. And then, of course, we always want to talk about culture because we know that culture informs how people respond to different events in their lives. And so it's important for us to become competent in being able to assess how individuals from different cultural groups might respond. And then I'll talk a little bit about treatment models and then future directions of what we should be doing and hopefully with perhaps what some of you might engage in the future. So when we think about types of trauma, we want to think about first sexual abuse, and that includes child sexual assault as well as human trafficking. We also want to talk about mass and small-scale interpersonal violence, natural catastrophic disasters, transportation events, fire and burns, community violence, suicide, and then, of course, life-threatening medical conditions and epidemics. And then, of course, lastly, I'll talk about compassion fatigue. It's important for us to add this as a form of trauma. It's secondary trauma for those of us who are responding and providing services for those impacted by trauma. And it can be as devastating for us as it is for the clients whom we serve. So it's always important to add that element and be able to talk about that. So first, let's talk a little bit about natural disasters. We get a lot of attention in the media about natural disasters, and typically that will be widespread and also will be in social media, on the internet, and so we hear a lot about these in other parts of the world. So you've already heard that I've been involved in some of those things, such as Hurricane Katrina in the Gulf Coast of the U.S. And also I provided consultation after this tsunami and the nuclear meltdown that was in Japan. Also, it was mentioned, I went to Haiti a year after the earthquake there to provide services. So I've either provided consultation or I've gone to particular regions of the world where there have been these natural catastrophic disasters. So generally they're large scale and generally not directly caused by humans. They often are death producing because of these events that occur in the natural environment. They also adversely affect a significant number of events, so there's this domino effect that occurs that can create more damage than just the disaster itself. And the individuals affected are not otherwise connected, meaning there are sometimes these critical events that happen perhaps in a workplace or a school or in a neighborhood where everybody already has existing relationships, so it's happening to that group of individuals. So they're a group and they are connected in some kind of way. Whereas natural disasters are defined by this aspect of just unrelated human beings. So if you take a look at, for instance, the 9/11 event in the U.S. in New York, where people impacted were in a office building, but there were several businesses in the office building. There are also businesses in the surrounding area that were impacted. So these are people who are not necessarily connected to each other, but they're all impacted, and that the severity of the disaster is that it often is death producing. So it's important to think about that and to differentiate natural disasters using these 5 criteria to be able to understand. And those criteria will help to dictate how you would assess as well. Another type of trauma would be sexual abuse, and since we're talking about children and adolescents or youth, we'll talk specifically about child sexual abuse, and that does include molestation, assault, sexualized play, as well as incest. And some time ago, let's say over a decade ago, I'm sure, I worked in New Orleans, and I actually created a center. It's called the Children's Crisis Unit, and there I trained a staff of students who were able to assess, treat, and also be able to evaluate the work that we were doing with children from birth through the age of 5 years old. And so we would receive referrals from the courts, from other clinical people, from the YWCA and their rape crisis program. So we would get recommendations from a wide geographic area and from many different disciplines, people who actually work with children. And they wanted us to first assess for veracity of the allegations to determine whether or not the child had been abused. And once we were able to do that, then we needed to intervene based on our determination of what the actual issue was. And oftentimes the interventions involved the parents, but we were able to do direct interventions with pre-verbal children as well as the 4- and 5-year-olds who were also verbal to be able to articulate what might have happened to them. This does include a full range, as you can see, of actual contact that one might have with a child, but also it does include children who are impacted by witnessing sexual activity that's inappropriate for them developmentally, and how that might impact their growth and development on several levels. Probably the most extreme of these would be incest, because we know that incest can, it has been correlated with other forms of psychological trauma, and one of them being dissociative identity disorder. And so it's important to be able to understand the full range of child sexual abuse and what some of the symptoms might be, as well as what the interventions are. And I'll talk a little bit about that later. Another would be rape and sexual assault, which we define as non-consensual sexual penetration through the use of or threat of force. Although this is included in child sexual abuse, because we're often dealing with adults who may have experienced sexual assault as a child, and it may have informed some of their behaviors during their adolescence and also in their adulthood, it's important for us to take a look at sexual abuse sort of over the developmental lifespan. And then finally, sex trafficking, which is defined as forced or coerced recruitment, transfer, harboring, or receipt of individuals for commercial exploitation. The last time I was in South Africa, I had an opportunity, I was in Cape Town, South Africa. I had an opportunity to go to one of the museums there that provided a lot of information about sex trafficking today. A lot of times people think that this is something that's happened in the past, it's historical, but in fact sex trafficking is something that's very much alive today. And there are some really good advocacy organizations. So if you were interested in learning more about how to work with this particular population, there are some great agencies for you to connect with. Next, in terms of types of trauma, I'd like to talk a little bit about both mass-scale and small-scale interpersonal violence. And as a part of that, we would include war, terrorism, physical assault by a stranger, and intimate partner violence, as well as torture. So I can tell you of these that even though I've done quite a bit of work in the area of trauma and working with children, that in fact I've only actually dealt with 2 of these 5 areas in particular. And one is the stranger physical assault, where I've been called in as a consultant to actually work with a client, and the other is intimate partner violence. But torture, terrorism, and war are, unless you really specialize in those areas and develop training, specified training in those areas, it's unlikely. I do have some mentors who actually do this work and who have provided training for me in these areas. And it's also possible to work with the Red Cross so that you can be someone who is on call when there have been issues related to war, terrorism, and torture, so that you can actually be someone who provides those. What I think is important at this point is to understand the differences between these events and how they might impact your assessment and intervention when working with children and their family members. So with war, we're really talking about violence that involves high numbers. So it's very different from an individual who might assault another individual, but rather we're talking about high numbers of assault against high numbers of individuals. Terrorism is a little bit different from war, is in the sense that, one, it's very intentional, and also that there are aspects of this that are not really associated with wartime. And then finally, torture is typically associated with the intentionality of pain and suffering that has been inflicted. Okay. And then transportation accidents. I'm sure you've heard about a lot of these related to airplane crashes, train derailments, and then also on the high seas. And then, of course, motor vehicle accidents. Again, because I trained to be a Red Cross disaster mental health volunteer, I actually did experience a lot of these kinds of critical incidents that do involve adults as well as children, and have been trained to be able to respond to these. So this is also more commonplace if you're going to be a disaster volunteer, someone who is called when there's been an incident such as this, to work with the first responders, such as the firefighters, the paramedics, the law enforcement individuals, as well as the medical personnel, such as the physicians and the psychiatric nurses, psychiatrists who are called to the scene. So if you train to become a disaster mental health person, then you would be part of this first responder team that would come in immediately following something like a transportation accident. And that would also require more specialized training to be able to do so. Next, I'll talk a little bit about fire and burns. So house fires, industrial fires also, fireworks during some of the festivals that occur, barbecue incidents that occur, and then of course we always have the human element of the interpersonal intentional acts when people are having conflicts, oftentimes people who are experiencing marital discord. I've also been, I think I've been called into all of these as a Red Cross disaster mental health volunteer, or in doing my international outreach. I've been involved in all of those. And that, I would say, also would be participating as a member of the first responders team that comes in. So that's very different from, for example, I talked about going to Haiti a year after. So it's not the same. It's not the same kind of services. But this would be very different coming in immediately after something has happened, and you're there as part of the chaos that's going on, and you're there to try to bring solace, to help people to be able to recover very quickly, and also to bring some calm to the situation. Next, I'll talk about community violence. So what's different about community violence is the pervasiveness of it. So often assailants are known, and they generally are people within the community. And if people are not experiencing violence that is against them, that they're witnessing. And so the work that I've done with children and community violence has been mostly children who've witnessed violence in their neighborhood. So not necessarily that these children have witnessed violence against a member of their family, but they've witnessed violence just sort of in the community. And so this becomes something that has a slow impact over time on children and their development, and children can actually have some very serious responses to this that can have implications for their academic achievement, their ability to have normal interpersonal relationships. Suicide. So this, while suicide can have a unique impact on individuals in general, it is highly traumatic for children in particular. Suicide, as you probably have already learned through your own training, presents complicated grief issues, and that and part of that has to do with the guilt and shame that is associated with the guilt. So it becomes very difficult for individuals to resolve it. For children, it becomes more complicated because of their developmental level. So the younger they are, their ability to understand and comprehend cognitively what's going on is very difficult. And so children might make sense of the suicide in a way that compromises their understanding. And then lastly, as I mentioned, medical conditions and epidemics. In the work that I've done, I've traveled internationally. I mentioned South Africa, but I've also traveled to Botswana. And in both of those countries, I was conducting or leading an outreach team in both trips to work with communities and individuals who are HIV affected and infected individuals. And that was very difficult to do. As a supervisor, there were a lot of counter-transference issues for the teams that I brought on both occasions. And I think part of that is because we're so embedded in the community and people are hearing these narratives and the stories people have, and they're becoming very connected to these stories, that it becomes very difficult to withdraw. And of course, there are a lot of emotions associated with withdrawing from the community because of our emotional investment. But also, I was able to provide training to show and demonstrate what community-wide responses have been shown to be most effective in working with HIV/AIDS affected and infected individuals. For invasive medical procedures such as heart surgery, often there are step-down teams, and those teams will have social workers who will assist individuals and family members with connecting to community resources and social services. But there will also be therapists available. So professional counselors can be a part of those teams to assist the family and individuals in being able to deal with either a subsequent death that occurs, but also in helping people to recover and be able to resume normal lives. And those lives that they resume don't always take them back to the pre-surgery level that they were at, so their ability to function might be compromised as a result of the medical procedure, and so people may need assistance in accepting the changes that have occurred. And then, of course, traumatic illnesses such as cancer, brain hemorrhages, miscarriages of birth, and we also can be able to assist people with that form of trauma as well. And I said I was going to talk about compassion fatigue, where I don't want to take up too much time talking about that, except to say what I've already mentioned is that we do experience physical, emotional, and psychological trauma as a result of working with traumatized individuals. And this is sometimes called secondary traumatic stress syndrome. The researchers are not in agreement about the terms that are used. Some people use compassion fatigue and secondary traumatic stress and burnout interchangeably as though they all mean the same thing. And other scholars don't agree. They think that these terms are very discrete in their meaning. So I just give you my opinion. I think that there isn't enough research to support different definitions, and that it's very murky right now. It's not very clear. There isn't a sufficient amount of research to be able to offer that. So for the purposes of this workshop, this webinar, compassion fatigue and secondary traumatic stress are similar terms. Now, in thinking about our historical response to disaster and children and adolescents, what's important to understand is that there have been several critical incidents that have occurred, and often we hear about the disaster of Chowchilla, California incident, and this is the incident where the children on a bus were kidnapped. And then the Jupiter incident is the incident of the children were on a boat, and very few children survived that incident. So that really sparked this work among clinicians to really think about how do we assess and treat children who are experiencing disaster, and how do we do that differently than the work that we do for adults. It was also as a result of these incidents that researchers and scholars began to create instruments that were designed specifically for children and their developmental levels. But prior to that, we were still using an adult model, and applying it to children. Actually, I think, my opinion is that that's what a lot of clinicians do without thinking about what's necessary developmentally for children. They take what we know about adults and what interventions have been shown to be effective for adults, and they just apply them to children. This is problematic primarily because if we were working with younger children, for instance, I mentioned that I created a training center to work with children 0 to 5. There are a lot of things that a 3-year-old cannot do. And so often you'll find these clinicians will work with the adults only and provide interventions for the parents or caretakers to use with children, to use with their children in their home. I don't have that particular view. The training that I've provided provides direct interventions to young children. And so I think the more that we look at the developmental needs of children, the better able we are to assess and treat them following a traumatic event. The next critical time in this historiography of working with children is 9/11. So after September 11th, here in the U.S., there were several things that we began to understand. One is that we began to move away from the more conventional assessment instruments and started thinking about using more of drawings and more of the projective instruments or assessment tools that we have. So what you'll find is following 9/11, you'll see greater emphasis on the use of children's drawings, for example, not only to assess to see what children might be thinking about or ruminating on, but also to allow children to tell their story. So it elicits narratives for children. And then we can also use it to re-story children, to have them to move toward recovery and resolution in some kind of way. But it was post 9/11 that we really began to see more emphasis on these types of assessment tools in working with children than the more conventional instruments. And then finally, when we think about post-Katrina and the Gulf Coast, the Hurricane Katrina, the impact of Hurricane Katrina really did provide us with new information. So there were some precedential aspects of the impact of Hurricane Katrina. So the first is that the U.S. had never experienced a disaster that covered such a large land mass. And it really altered the way in which we think about the psychological first aid. So our motto has typically been that if something happens in a house, for example, then we reach out to the surrounding houses or neighborhood to be able to provide support to that house. If it happens to a neighborhood, we reach out to the surrounding city, other neighborhoods in the city to be able to respond. If it happens to a city, we reach out to the surrounding geographic area. If it happens to a state, we take a look at the surrounding states and we send people in to be able to assist. Hurricane Katrina happened over multiple states, so these geographic areas or these political domains were across these large areas. So it impacted Louisiana, Texas, Mississippi, Alabama. So it's a huge area. And so this typical response model where we bring in people from the outside became very difficult to do because many of the responders in that landmass area were also impacted. So professional counselors, social workers, psychologists, psychiatrists, physicians, these people also had homes and children in schools, for example, who were impacted. And so it was very difficult to apply this particular model. Another way in which Hurricane Katrina changed the way in which we look at natural disasters, particularly those that are catastrophic is also in thinking about the duration of the impact. So typically, after about a year, we are able to refer people to their local resources and people can begin to move on. Well, actually, this year marks the decade anniversary, so it's been 10 years this August since Hurricane Katrina. And I know I've gone back to do trainings recently, and people are still very much impacted. Also, when we think about the devastation of how people were impacted, Hurricane Katrina really provided us with new information and transformed disaster mental health response in the sense that we were able to look at secondary impacts. So we were able to look at substance abuse. We were able to look at other forms of comorbidity in terms of mental health issues. We were able to take a look at the mortality rates as well, where people didn't necessarily die directly from Hurricane Katrina, but people died from the emotional fatigue of trying to recover from the event. So we are still experiencing. So some people in New Orleans would actually say that they're not experiencing post-trauma, but rather they're still in the trauma. Another aspect of thinking about working with children and traumatic events is really taking a look at this cumulative trauma, the idea that people who experience, for instance, interpersonal trauma often feel that they're at risk for re-victimization, and often do unless we're able to remove them from their circumstances. And so when we think about assessment for interpersonal trauma and we're working with children, we often want to ask the question about the environment. So is there safety, for example? It does no one any good to come to counseling and be able to receive assistance and some resolution only to go back into the same environment to be re-victimized. Another is in thinking about developmentally, what can we expect? So for instance, children who are survivors of child sexual assault are often at risk for re-victimization during adolescence. And what that means is that what we've shown, what has been shown from the literature is that at each stage of their development, CSA survivors are likely to revisit the experience. And so during adolescence, what we know is that they're at risk for acting out sexually. And so without this knowledge, it's very difficult for them to be able to be clear about what's happening to them, to have some control over their responses to what's happening. And also it assists their family members and their support network to help them to be able to maintain safety. Without that, they're very likely to experience re-victimization and place themselves at risk. Also, children who experience trauma are likely to experience multiple traumas or multiple symptomatic responses to the trauma. So trauma is very complex for children as well as adults, and so we really do need to do a good job of assessing in order for us to be able to be clear about what it is that we're seeing, to try to minimize the differential diagnosis as much as possible, and to provide the best form of treatment possible. And to do that, as counselors, we believe that an ecological perspective is very helpful because it provides you with a 360-degree view of what's happening with a client. Provide you with information coming from the home, possibly the school, possibly if they are involved in any religious or faith-based activities, if they're involved in any social activities, to be able to consult with their physician, the pediatrician who might be assisting. So it really provides us with as much information as possible to reduce any likelihood of error in our conceptualization of what the issues are. It would be remiss of me to talk about children and traumatic events without talking about traumatic stress, not just because this is my area of research and I'm interested, but also because I mentioned earlier the idea that some children experience pervasive stress and or pervasive stressors, pervasive trauma. I mentioned it when I was talking about community violence, but there are other kinds of situations where children might experience pervasive stress. So although before, prior to about 10 years ago, most of the research that attempted to talk about traumatic stress, we're trying to talk about it in terms of this broader, larger conversation of talking about trauma, or they were talking about post-traumatic stress disorder. But the pervasiveness of traumatic stress that comes from, for instance, what I write about is marginalization, social marginalization, can also have these similar impacts. So over the last 10 years or so, more scholars are researching the pervasiveness of environment and how it impacts individuals, and also how they're resilient as well. I've written both about the traumatic stress as well as about how individuals have been resilient despite the pervasiveness of their marginalization. So one is thinking about, as we expand this understanding of trauma, is thinking about both one's perception, how people are perceived, and how individuals perceive themselves, as well as what are these contextual factors that impact their experiences. And then also the idea of looking at systemic oppression. So looking at, for example, how women experience the environment. You've heard about women experiencing, for instance, the glass ceiling as they try to advance in corporate environments, for example, and that women are not experiencing the same pay level, do not experience advancement in the same way. And that this has also been proven in academia as well, in terms of how women get promoted through their faculty positions. So it's very clear that women, for example, are experiencing institutional or systemic kinds of marginalization. Another is looking at people who historically have experienced marginalization due to their cultural values and mores. Another is a more recent thing. We take a look at people who are sexual minorities, LGBTQ individuals as well. So if you take a look at bullying literature in schools, also we also look at ways in which LGBTQ children experience marginalization in schools, and in fact, some of this emerging literature talks about their traumatic stress and the stressors in schools and how their peers are positioning them. And then the idea that trauma is only something that, the idea that trauma is negative, sudden, and uncontrollable is still a core element of talking about traumatic stress. But what makes it different is the pervasiveness of it and the fact that it's institutional in the way in which people are marginalized. So now we get to the good part of talking about children's responses to trauma. So even though we can look developmentally and look at, for instance, preschool children, and we can look at primary school children, secondary school children, and there are different kinds of responses based on their developmental level, but these 5 elements are core. So if you were thinking that this is an area that you want to gain confidence in, you would want to look for some form of fear and anxiety, sudden panic or distress because of some object or some place, or some person that causes the sudden distress. Typically, they experience separation anxiety when it's time for them to, for instance, be dropped off at the nursery or go to school, or at any time when their caregiver, mom or dad or whoever the caregiver is going to go away. They typically start having a tantrum of some kind and become very anxious in their response. There's also a startle response and a nervousness. So sometimes if, for instance, a door closes and it shuts really loud, or there is something falls, like a book falls or something like that, a child will be very startled, more so than they would under other conditions. And then also there's the fear and denial. So as I said, depending on the child's developmental level, this could look a little bit different. So for instance, the idea of fear and anxiety for, let's say, a 3-year-old who might have experienced trauma, one of the ways that you might see it is that there might be developmental recidivism. So a child who had already been trained, potty trained for a year or so, that 3 or 4-year-old might have a bedwetting incident. So you would look for that. For an older child, you often would look for, like a teenager or adolescent, you might look for a change in personality. So this child was normally outgoing and very talkative, has lots of friends over and so on. You find that now they just stay in their room, they don't talk to their friends, they're not very social anymore, and they're not very talkative. And the opposite is also true. If you had a child who was normally very shy and didn't say very much, and then you notice that they're very gregarious, they're talking to everybody, it's very out of character for them, that you certainly want to have the caretaker to respond and recommend that they see a professional. For adolescents in particular, you'll see acting out. You'll often see that they're accident prone. That's another one, to see why are they getting so many bruises, for instance, what's happening to them. And then also sleep-related difficulties, which could be trouble sleeping as well as sleeping too much. So it could be either of those. So any of those might be important. Now, the severity often will dictate the responses, but also issues around culture, the characteristics of the stressors. So I just went through that long list of types of stressors, of traumatic events, and each of those carries different characteristics. There might be different responses. The specific role of the child abuse or neglect that's occurring. And so it really depends on what the dynamics, the family dynamics are. And then the idea of social response, support, and resources. So there, when we take a look at things like economic marginalization, so we take a look at low-income families, that the social response typically, in the U.S. at least, is not the same, that people who come from more low-resource families, low-resource communities, typically have fewer resources and support, and it's very difficult for us to be able to get those resources to them, or there's a lack of concern on the part of the government, or a combination of all of the above. But we know that there's differential support that's provided to people in different economic communities, and that will also dictate what it is that you see. Now, post-traumatic stress disorder comes with very specific kinds of characteristics, and typically following, for instance, a large catastrophic disaster, we know that we'll see PTSD responses for just about everybody for the first couple of weeks. But after about 2 to 4 weeks, if you see people with the same symptoms, that we definitely want to go in and take a more serious look at what's going on. And as you can see, we have psychotic depression, major depression, anxiety, And usually, as I said, there's comorbidity as well. And of course, the comorbidity, as I mentioned, drug and alcohol dependence. There might be psychosis. And of course, we should never overlook traumatic brain injury as well. I mentioned already about culture, so I'm going to sort of skip over this one. And the idea that there are culturally bound stress responses. How people respond has a lot to do with how they've been raised. And so some people will be able to want to talk about it. Other people will not want to talk about it. Some people don't even see certain behaviors as problematic, and some people might see certain responses as more problematic than others. So it's really important to be able to get to know the cultural values of the clients that you're working with, so you can get an idea of what do they define as normal, and what ways have they attempted to address this within their cultural value system, what resources have they had historically, and then think about what it is that you'd like to offer that might fit within their definition of healing or helping. So issues like the idea that the spirit, the mind, and the body or matter, for example, are very separated within Western culture and not so much in other cultures, not so much in, for instance, Asian culture as an example. So thinking about that, thinking about how people define their identity as individual or group-oriented. So is it a more collectivistic society or group? And that has a lot to do with the choices that people are going to make. So when you think about treating for traumatic events with children, I've already mentioned safety, but also stability, the idea that it needs to be a positive therapeutic relationship. And I know that sounds like that's intuitive, but it needs to be said. That we definitely need to work on client-centered interventions, because really what you're trying to do is minimize the space between. So the idea is that wherever you can come up with interventions that are as closely connected to the client's way of thinking, the more they'll comply, and also the more expedient your interventions are going to be. You need to think about counter-activation or counter-transference on our part. And I know that this is covered in your training, so this is just an emphasis, a reiteration of that for you, that we always need to think about what are our biases coming into this environment. And that is not only have we had experiences similar to those articulated by the client, or if we're working with young children, by the client's caretaker, but also how do we perceive this family? How do we perceive this child? And do we have any preconceived notions about this child? And as always, we need to think of the ethical issues about, are we honoring and respecting the client? Are we doing no harm to the client, and so on? So some of the short-term interventions that I've used in working with children. One is the story circle. I really enjoy working with the story circle in working with, for instance, caregivers, for them to provide narratives about either their experience or narratives about solutions, ways in which their families have solved this kind of problem before, because I want them to think about resolution. I want them to feel empowered that they do have the resources to be able to resolve the situation and recover. Another is the use of proverbs, and strangely enough, I've used proverbs with young children. So, and I've created a host of interventions that involve cards, posters, children's drawings where they draw what they think the proverb means, and so on. I've used a narrative approach in having them to do storytelling exercises, creative therapies, I've mentioned that, where children act out, but they tell their own stories. I've used, I mentioned we make dolls and we replicate their family. And also I do education, psychoeducation, where I just teach. Long-term interventions involve assessments. Sometimes it's doing ethnography by going into communities to educate or communities to get information or to try to develop support in a community because of a large incident that's occurred. It might also be to help the community to come up with ways in which they want to begin the healing. That's one of the things that I did in Haiti in helping people to develop, to work with artists in the community and to come up with some art project that would allow them to tell their story of survival and recovery to be able to do that. And I actually brought a retired art professor from Ohio State University with me to be able to work with the artists there. And then advocacy is a really important thing because we want sustainability for any interventions that are created with the community. We want to be sure that they're sustainable after we leave. And I mentioned already the idea that culturally responsive interventions are interventions that incorporate the values and the worldview of the communities of the clients we serve. Again, the idea is that provides not only sustainability because people understand it, they're not learning something that's foreign to their way of thinking, to their worldview. Instead, if we build on how they view healing and what's recognizable to them as healing, that they're much more likely to comply, they're much more likely to understand, and it'll go a lot quicker. So it certainly supports expediency in the work that we do. But it does mean that we need to work a little bit harder. So instead of us relying on solely what we've learned in the classrooms that might be much more conventional, it requires that we learn something about the communities that we serve, and we learn about their form of healing, and we think about the interventions that can be used that will be a partnership between what it is that we know as evidence-based interventions in counseling and what it is that people do within their communities. So what am I recommending? That, of course, that we take into account the client's realities and that we also respond to children's developmental needs and that we also think about their cultural background. And two, that we assume an advocacy role. We really do need to, one, respect the environment, the ecosystem that children are in. And so it means that we want to connect with and partner with existing resources that are available to these children.
Is it likely to think that the nightmares are related to traumas or events related to the child's experiences?
Well, yes, it is very possible, and that would be one of the warning signs. So that's a very good question. I mentioned bedwetting, and I almost mentioned nightmares, so thank you for bringing this up. I would include that in thinking about what are some of the red flags or what are some of the warning signs when we think about children and traumatic events. Nightmares would be one of them. So everybody has had, most people have had a nightmare before. But if you find that a child is having nightmares over consistently over time, then that would be a concern. And of course, where we can, we would ask, what is the nightmare about? Because typically there will be signs or symbols to look for. So if we were intervening with that child, we would ask them in a safe place, for instance, in our office, to ask them to tell you about it or draw a picture of what happens during the nightmare, because we want to give as much thick description about what's happening. But yes, is that a warning sign? Yes. But be careful. We don't want to assume that every child who is having nightmares has had some traumatic event, and that's not necessarily so. So we do want to continue to ask other questions. So we do want to ask about their behavior. Have there been sudden changes in their personality? We want to ask about that. We want to ask about whether or not there's any startle response. We want to ask whether or not there have also been changes in eating patterns, sleeping patterns as well. So we do want to go through, and actually there are tools that you can get. There are books, videos that you can get, and also there is a clinical interview schedule so that you can go through and ask questions to be able to rule out a traumatic event and look at any other differential diagnosis.
Wonderful, thank you. Another question
Mhm.
now from Robin. What do you do if culturally the abuse is allowed but not legally in our country? How do you respect the cultural aspect but protect the child in regards to explaining what is wrong and accepted in their culture?
Right. You know, these things come up over time, actually. So I remember in the U.S. when we started getting more information about working with um, people who were Southeast Asian refugees in the United States, and there were some parenting practices that were being discussed by clinicians about, and we were wondering what could we do, because what the parents were doing, they were actually cutting their children, and that was an acceptable form of parenting, of disciplining children, but not in the United States. So there was lots of discussion about what it is that needed to be done in response. This also came up again um, when we started getting more immigrants coming in from, I think it was Central Africa, where there was female genitalia mutilation and that discussion. So there have been several times in the U.S. at least where we've had these cultural values that conflict with the values within the U.S., which is certainly a much more Western-oriented perspective. So this is not new, and we are approached with it. So one is that I can tell you right now that we are bound by our ethical codes. So that's number one. In the U.S., because a person who is a licensed professional counselor is under state laws and state statutes, that they could lose their license if they violate our ethical codes that, and typically they're referring to those codes set by the American Counseling Association. So that's number one. However, it's important to understand that ethical codes are not as clear as we might think. So it's not that black and white. There are gray areas. So one is understanding that ethical codes are really supported by current practice. So for instance, if something that you were doing was called into question, then the first thing that a review board is going to do is to ask professionals, licensed professionals in the area, in your area with your expertise. So there are people, so if you're in a rural area and your practices look a little strange to people in urban areas, they're going to ask your colleagues in that rural area. In the case of cultural differences, they're going to um, they're going to ask people who also work with that population, and they're going to ask what are the practices in that region or in that area for um, for professional counselors working with that population. So you do have that on your side to be able to determine what you think is best for the particular client. What you can't do is use your own value system to make that decision. So I don't know if I've confused you even more. But Robin, basically what I'm saying is that um, one, that you have to think about the ethical codes and determine what is best or what's considered to be best practices and what does no harm to your client. The second is that you really do need to think about what are common practices in your area for that issue with that population. So that means that it may require you to talk with colleagues about how you think you want to handle that. What I am also saying is third is that what we do know is that you can't make the decision based on your feelings or your background or your biases toward the client or toward the particular issue. So it does mean that you need to find some way to get some distance between your value system and the decision about what's best for the client, and then to get support from other peers if you think that that decision is the best decision for that particular client or clients like that. So it's going to be different in different places, the response to that, but it does mean that you do need to be very clear about the cultural issues. You do need to make sure that you're not using your value system to be able to make that determination. And then you need to figure out how you're going to respond to it. If you decide that, okay, it's unethical, it's illegal, and it's immoral, and you've checked with that, you've consulted with legal people, you've consulted with ethicists, you've consulted with peers, you've consulted with your supervisor, and they're all in agreement, then what you need to do is work with that family to get them to understand how this is harmful to the client, but only after you've gone through you've gone through actually an ethical decision-making model. You've actually gone through the steps of an ethical decision-making model. And that's what I would advise you to do.
Thank you. Okay, I've got a question from Pamela now. Is there a different way of dealing with children who have witnessed domestic violence?
No, because that's one of the forms of trauma, is that the interpersonal violence. So the interpersonal violence is a term that used to be called domestic violence before. And so it's actually evolved so that it's intimate partner violence. But children who've been exposed to that kind of intimate partner violence will have specific characteristics. And so it's important. So again, in my slideshow, I mentioned that I've talked about these types of trauma, and thank you. And it's important to understand that these different types of trauma, and even the subtypes within each of the traumas that I've talked about, have different kinds of outcomes, and children have different kinds of symptoms as a result. So this one, in thinking about it, there are several. So one is, as I mentioned, it depends on how early and how long a child is exposed to domestic violence or intimate partner violence. How long have children witnessed that? So the effects, if it's long-term, so if a child, for instance, if a child is living in a household where mom and dad are going at it, either emotionally, psychologically, or physically over several years, right? Let's say that the parents decide they're not going to split up or get separated, or, they don't separate from each other or stop the violence until the child is, say, 14. So that's from birth to 14. The responses that a child will have will be similar to pervasive witnessing, like community violence. So we're going to see that same kind of thing. So what we know from the literature is that there are various responses. One is that children who witness that kind of violence can actually become adaptive and exhibit other forms of, or maladaptive forms of, interpersonal relationships. So they could do that. They also might act out, and you'll see greater signs of delinquency among these children. Also, what you can see is that children will also uh, take on and become victims of violence. In other words, they'll seek out relationships that mirror the relationship that they witnessed between their parents. And so you'll see that in their relationships, um, they will also be victimized by someone. And it's not always the same thing. So growing up, they might have witnessed physical violence where, um, dad was physically attacking mom. And growing up, the child may get into a relationship where their partner is emotionally abusive. So it doesn't have to be the same, but they can have multiple responses to that. Young children might have many of the symptoms that I showed on that slide of um, what do you look for. So if you were wondering if a child that you're seeing might be experiencing or might be witnessing domestic violence, you'll see the same thing. A young child will have signs of anxiety, sudden panic. They may experience separation anxiety. They may have a startle response, and you'll see the fear and denial amongst them. So yes, you would look for those same symptom trauma responses if you suspected that a child was witnessing domestic violence, which would be very different than if they're actually being abused themselves. If they were actually being abused, you'd see more severe symptoms. So you would see the bedwetting, you would see the nightmares, and so on. So you probably also see some reenacting. So you would see them while they're playing with their dolls or stick figures or whatever, you would see them hitting and physically abusing the doll just the way in which they're being abused as well. So yes, definitely that is one to be very concerned about, and you should assess for trauma symptoms if you suspect that there's domestic violence. Yes.
Okay, next question. This is from Sarah. How manageable are language barriers when undertaking trauma clients with culturally and linguistic diverse issues? Is it really useful to use interpreters in terms of building a therapeutic relationship between client and counselor? It's an interesting question.
Yeah, Sarah, I get that question all the time because I've traveled to Romania and I've traveled to Beijing, China, to Malaysia. I've been all over, and people ask, "Well, do you speak all those languages?" I don't. I don't. I just get barely by with some of the language. I guess I barely get by with English, for that matter, because I'm not sure if you can understand me today, but it is possible. So you in an ideal situation, you want to bring in an interpreter. And of course that gets complicated depending upon what the issue is, how comfortable the person feels, your client feels in being able to share intimate details of the problem with a third person in the room. So it does get a little complicated, and you do need to get creative to be able to get someone. I've gotten a family member. Sometimes it's been one of their children. Sometimes it's been a sibling. Sometimes it's been a neighbor, a very, very close friend or neighbor. Sometimes it's been a religious leader. I've had ministers, priests. I've even had indigenous healers to come in session and interpret what it is that I'm saying, and also interpret for me so I better understand what the client is saying. So in the best situation, we have an interpreter there. When I was working, a lot of the countries I've been in, people are able to speak English or some dialect of English, so I've been very fortunate in that sense. When I was in Haiti, I had funds and I brought or hired people who interpreted for me. So in some spaces, I have just paid to have someone to come. When I was in private practice, as I said, I was able to get family members or religious leaders, someone close to that person who was willing to allow a third party to be in the room to be able to tell the story. So in the best of circumstances, you have an interpreter. I think language is a barrier, and not just um, the syntax of speaking another language. It's also how people think. So language is a way in which people express themselves. And so therefore it's connected to culture. So it's not just whether someone speaks French or English or Swahili or whatever. It's not just that those are different languages. It's that those languages express certain concepts. And some of those concepts don't even exist in other languages. There isn't a way to articulate it. So sometimes, even when I'm working with a client who speaks a native language that's different from English, and it's complex, it's something that they're trying to unlock, sometimes I'll just say to them, say it in your native language. And they would say, but you won't understand me. And I say, look, you're not talking to me, you're talking to you. So you need to be able to express it in a way that unlocks a lot of the obstacles, the emotional obstacles that have been there. And so language can be a tool to free people, to liberate people from a lot of, ways in which they're stuck. So the easy answer is, yeah, language can be a barrier, and so therefore it's best to get an interpreter. But I'd say think bigger than that, think deeper than that. So even if you're speaking to someone and you're speaking in English, sometimes people need um, to think about uh, their values, and that the problem may be connected to the way in which they're thinking about it. So it's important for us to think about that, that when people are stressed, they tend to go back to their earliest years. They go back to sort of their base, their beginning, their foundation. It's sort of like uh, sometimes I know when I was raising my children, and I know like well, the first thing I thought about when way back when I was raising my children, who are now grown, and my first thought is, oh my God, I am not going to do some of the things that my parents did for me. Definitely not. I'm going to, be more attentive, or I'm going to listen to what they say and not assume that they're not telling me the truth or whatever. So that was it, but I found that when I was really, really stressed with my children and they're really like working my last nerve, I found myself saying something my parents said to me. So it would just come out my mouth. I'm like, oh my God, I'm my mom, So that's how people are. It's like when they're very, very stressed, they will go back to their foundation. And so the same is true for how language operates. And so even if people are speaking English with you, if their English, their culture of origin is slightly different, that, they have slightly different values or whatever, is that you really do want people to go back to their roots, to be able to articulate it in that earthy, foundational way, to be able to unlock some of the problems that they have. So I really give you a long answer to a very simplistic question, but yes, language is very, very important to the work that we do.
Wonderful. Just got a couple more questions before we close it up because time is running out. So the next one is by Marilena, and her question is, how would you approach a situation where a child has closed up, which she clarified by the person's not talking because of a traumatic incident?
Hmm. I would say be patient. I would be patient because Children shutting down, well, shutting down is also one of the symptoms of trauma. It's part of the constriction of trauma, so it's expected. And I think that when we're working with our clients, it's important for us to bring calmness, surety, and faith. You know, the idea that counseling is a humanistic profession is suggesting that there is a faith in human beings that they want to self-actualize. That's what humanism means. That's our basic fundamental press as human beings, is to self-actualize. So thus, when we see people stuck, we have to have this belief that something external is going on that's preventing them to do what most human beings want to do, that what we're bred to do, what we're meant to do. So that's really important. The second is understanding that human beings are relational, and just being in relationship is healing enough. And so again, if we know, if we are bred that human beings are meant to be relational, that's how we're designed, and you find people who are shutting down, that is contrary to how we're wired. So we have to have faith and belief. So sometimes when people are shutting down, some of it is sitting with them through the experience. So a lot of times when we're working with traumatized clients, and particularly children, is that we want them to get fixed real fast. You know, we want them to get over it. It's sad, it's terrible, whatever it is, whether it's a complicated death like suicide, whether it's that they've gone through some catastrophic natural disaster, whether it's been sexual assault, whatever it is, it's sad. I guarantee you that. It's sad. And so some of that we need to be able to work with, to be able to sit with people and be okay with that. That is a normal response for people to want to shut down, particularly if it's been very traumatic. That makes sense. And I think exuding that, I think of presenting that with our clients is important. So we don't want to inadvertently have counter-activism, that counter-transference, where somehow our impatience for them to get better is being communicated, even non-verbally, we're communicating that. So some of it is really allowing us to sit with people with the faith that this is a stage, this is a step to get to the next step. And it's okay to be in that place where they want to shut down. And if we're exuding this thing of I'm with you while you're shutting down, I'm with you, I haven't left you, I'm not going anywhere, and I'm certainly not going to leave you behind. So I'm not going to leave you in this state. But I do understand that I need to emotionally hold your hand through the shutting down because it hurts and it feels bad. So it's an important element to acknowledge, appreciate, and have faith in human beings that they will move through that stage. And just that very piece of what we call the therapeutic alliance, of aligning ourselves with our clients where they are, is therapeutic enough sometimes to move to the next level. And what we do, I mean, there's no magic bullet. So let me say that right now, that I don't have a bag of magic tricks of, okay, for that issue, here's the next thing. So I won't say that. I will say that you do need to have something to start with. So we know that some things work. So we know that creative exercises work. So trying to get people to write. I will give you an example. I had an adolescent who I worked with, that's maybe 20 years ago. And this young man was about 13, and he was required to come and see me. And he came every day, every session. So every week he came, and he sat and he said absolutely nothing. He said absolutely nothing. Now I had a supervisor and I was recording my sessions, and I was a little nervous because I had a 50-minute session and there's nothing on it other than me welcoming him to the session, telling him to sit down and asking him, how are you? And then getting nothing for the remainder of the session. This happened 3 times where I had nothing on my tape, where we sat there in silence. But I had a great supervisor, and she told me to wait. She told me to just wait with him. And the first thing that happened is he drew, because I always had crayons and paper there. And on the fourth visit, he picked up a red crayon and he drew what I saw as like uh, raindrops, like red raindrops. And that was a whole page. That's it. And I looked at it, and me and my silly privileged self, I looked at it and I said, "Oh, raindrops." And he said, "No, that's blood." And that was the beginning of our relationship that very day. And he educated me, he taught me, and he talked about, he was someone who witnessed a lot over his lifetime, witnessed a lot of community violence. And gradually his story unfolded of what was going on. But it took 3 sessions of blank tapes for me to sit there and be with him and have faith that he would begin talking to me about the trauma that he experienced. Or why was he silent? Why was he shut down? It took a while, but he did. And I have many other stories that we don't have time for. But I think sometimes the best intervention is to just wait, wait with, not wait for, but wait with our clients as they move from not talking to talking, as they move from being mute to being able to articulate, what's going on in their lives.
Wow, that's a great answer. We might have to do a webinar on stories. Okay, now one final question just to close out today's wonderful presentation. And this one kind of overlaps with your previous answer, so maybe there's something you can add to it. If not, then we can move on. But thinking about refugee children who have experienced all manner of horrific trauma incidents, what's the first step approach? Now, the person added, this is Rebecca, by the way, I know you said that the child's initial safety is of paramount importance. However, keeping in mind these children are now safe, they may not actually feel this way. How would you help them gain your trust and get beyond that fear?
Mm-hmm. Yeah, you're absolutely right. You're right on target, Rebecca. Safety is the number one thing. And I would say, I think we think they're safe, but I have not had the experience with children who are refugees. I have not had that experience. They don't feel safe. Neither do their parents. So the adults don't either. It takes them a long time, I mean years. It takes them a long time to begin to feel safe in this environment. It's hard to believe that issue of denial is there. It's hard for them to believe that they're no longer experiencing that. So that it's ever present. It's more present than you think. It's ever present for them. The interventions that I've found to be helpful, depending on what the situation is, when there are refugee communities, there are some great community-wide interventions that are fantastic. As a matter of fact, we have a doctoral student here at the University of Cincinnati who's working with the Burundi population. And this is an ethnic group in Africa. And they're here. There's a whole community of Burundi families here in Cincinnati. And he's developed a community garden with them. And the reason why he developed that is because they don't have a concept of Western forms of counseling, of what we consider to be counseling. They don't. So try to talk to them about, they need to be sitting in session to try to, recover from, the atrocities that they experience and the reason why they left their home country. They wouldn't come because it doesn't make any sense in their world. So their worldview doesn't account for that. But we understand that all cultures from the beginning of time always had a form of healing. So there were always healers in communities. Today, in Western societies, we call it counseling. But the idea of healing existed since we've been here as human beings. So we always want to engage in that conversation with communities and ask them, what does healing look like? How have you um, um, been able to recover from traumatic events, either as a family or as a community, as a culture? What things have you done to be able to resolve these kinds of things in the past? And then what you want to do is to develop something on top of that. So I would start there because they are their support, and we're not. So we want to develop something that is recognizable and sustainable, always recognizable and sustainable to that particular community. So I would always say start with the community and work your way out. Always start with being culturally responsive to the community and make sure that whatever it is that you're doing builds on their worldview and values. Always, always, always. When a child is isolated from their community, and that happens sometimes because of the situation in the home country, individuals might be separated from each other. Again, that happened here in the U.S. During following the Vietnam War, and so there might have been, refugee, one child going somewhere, living somewhere in Michigan, and another child living somewhere in California, and so people were separated in that way rather than coming to or coming as a family or community or coming to a community. So we know that that happens sometimes. That also happened after the Haiti earthquake. There were people all over the world who said, I will take a child. If they're orphaned, I'll take a child. And so you have children who are isolated from their home community, from people who share the same values. And that's okay. It just means that when you're thinking about how do you establish trust and how do you help them to expediently recover, that you have layers of not only recovery from the particular trauma, but then you've also got acculturative stress going on as they're trying to adapt to a different culture. So you've got multi-layered issues. My recommendation is whatever it is that you do, that you co-counsel. Because it's very complex, my recommendation is that you find someone else to counsel with you. So when you go into session, it's not just you, it's you and your supervisor, or it's you and a colleague who are working so that you can spend time debriefing after to be able to tease out these complex issues, to know what it is that you see, what do you want to do to intervene, and what resources are there for that child who might be isolated outside of their home culture.